welcome to our Nuts and Bolts series. This is episode 2, and today we're going to be talking to an orthopedic SHO, Dr. Danny Chandler, who's very kindly joined us, and looking at how he enjoyed orthopedics and what his thoughts are and advice is for those of you who are currently doing orthopedics or will be. So welcome, Danny. How are you doing?
Yeah, I'm not too bad. Nice morning.
And had a good Easter weekend?
Yeah, it was great Easter weekend. Yeah, got to play some golf. So
awesome, yeah. Excellent. So we're going to jump straight into it. So I'm going to start kind of before we hit the orthopedic placement. So what made you get into orthopedics in medical school or foundation years?
So I think, like a lot of things at medical school, when you are on a placement and then you have a team or you have consultants and supervisors that show a lot of interest and are really keen about sort of their field, and that sort of rubs off on you a bit. So when I had my MSK placement at Warwick Medical School, I actually had a George Eliot Hospital, which is a DGH in Nuneaton. The team there were actually fantastic in in terms of teaching and sort of getting us involved in things. I spent a lot of time in the trauma theatre there during my placement, and that sort of was what made me want to consider orthopedics as a future career. And then from there, it just sort of gave me that push to apply for the academic foundation program that they have in Coventry for orthopedics.
Okay, and during medical school, because I sometimes think, or I sometimes get told by people that it's difficult to get interested in surgery because you can't really go and start doing operations as a medical student. So apart from sort of that team environment that you said, was there anything else in particular about orthopedics?
Yeah, I mean, I do agree. I do sort of agree with that. That whole it is difficult to get interested in surgery. I think as well, it very much depends. Like I said, it very much depends on where you are and things. I think just in terms of the way I think, surgery makes a lot of sense. So for me, it was always something that I thought I would consider going into. I like the whole idea of the you have a patient and then they come to you with a surgical problem, and then you essentially sort out that surgical problem with surgery, and then at the other end of it they're essentially better. I think that in itself is sort of rewarding, and I always thought that way through med school as well. So I think that was one of the things that got me interested in it. But like I said, in terms of being at medical school, it is very difficult to get interested in surgery if you don't have, well, firstly, if you don't show interest, or you don't put yourself out there, and also you don't have a team that are willing to take you on. A lot of people at medical school, they go to theatre and then you end up just standing in the corner. You don't really get involved. You don't really see what's going on. And I sort of understand that. But, when you get that one opportunity when a consultant or registrar asks you to scrub in, and then you're actually at the table and they're explaining things to you, showing you the anatomy and giving you an appreciation for what they're actually doing. I think that really sparks an interest for a lot of people.
Okay, all right. No, that's I understand that. But when so you've done medical school, and I'm sure you've heard lots of things about orthopedics before you started your orthopedic placement. What kind of things have you heard from your friends or people who've done placements?
So yeah, I mean, there's always the stereotypes and the jokes that go around about orthopedic surgeons and how they're not really medics, and how they're only focused on the fracture to the detriment of everything else. There are those jokey meme videos and things where there's essentially saying there's a fracture, we've got to fix it no matter the cost, type thing. And I think there's always the stereotype as well. And I don't necessarily know where it comes from. It is obviously a very historic thing of orthopedics being this old boys club type thing, where it's about who and you have to have a certain type of personality to sort of fit in. And having experienced orthopedics at medical school and as a foundation doctor, I don't think that's necessarily the case. I think a lot of that, if it did exist, has changed, and it's very inclusive now. There are lots of different people, and even within orthopedics itself, there seems to be a lot of variety of what people can do. So there's a place for everyone.
Okay, fine. And you've done a F2 placement already. You're currently on your academic block. So talking about the clinical placement, can you just talk us through a typical day or a typical week for yourself as an SHO?
Yeah. So in terms of a typical day, so our normal working days are supposed to be from 7:30, which is when the trauma meeting starts in the morning, to about 4:30. And on a typical normal working day, you would go to the trauma meeting, which is where we go through all the patients that have come in over the last 24 hours on the on-call take, and then also discuss any other patients that the consultants want to discuss in the morning. And that can actually be a very good learning experience for us as well, when the consultants take the time to go through the imaging and explain to us what's going on and try to give us some of their thought process. It's usually quite a fast-paced thing, so we don't always get that, but when we do, it's a very good opportunity to learn things, and also we get to see a lot of imaging. After the trauma meeting, we split off into our team. So at UHCW, it's split into 4 teams. Each have their own set of consultants, so there are 6 consultants in each team, typically 3 to 4 trauma consultants, and then some elective consultants too. And then we would do our ward round. So I would say that on average 2 to 3 times a week it'd be a consultant-led ward round, and then the remaining time it would be the SHOs that see the patients on their own, and also the house officer. We have one F1 that moves between the teams. So on a typical day, we would split the patients between our team, see the patients, come up with any jobs that need doing for each of the patients, and then we would sort of meet up after we've seen all the patients, and ensure that everyone has sort of a fair workload, split out the jobs evenly and get the jobs done. This typically on most days would take the morning, or a part of the morning, which would leave the rest of the day free for other things. So a lot of the time on our on-call days, there's a fracture clinic running. So as the SHO, we can go to fracture clinic, we can see patients, and then present them to the registrar or consultant, and then dictate the letters afterwards. And I think that's a really good opportunity because we get to follow up some of the patients that we may have seen earlier in the block as well, which is great. And then on the other days, there's always the opportunity to go to theatre as well. So as an SHO, generally we have a day that we're assigned to go to theatre, as it were, and that's based on when our team was on call. So it's the day after that our team was on call that we go to the theatre, and that's so that we can essentially see the operations and help assist and potentially do some of the operations on the patients that we have seen ourselves, which I think is a good thing. And then there's other time for sort of things like audit and research and things. So that's a typical day. And then we have other commitments. We have on-call commitments. So we generally are on call once every 2 or 3 weeks for one day, and that's a 12-hour shift. And our job as the SHO then really is to assist the registrar. So unlike most hospitals that I'm aware of, especially the smaller DGHs where the SHO would take the orthopedic referrals, as UHCW is a major trauma centre, the registrar takes all the referrals, and as the SHO we go and assist them with that. So that whether that be clerking the patient initially until the registrar comes down, or seeing the patient with the registrar, note taking, and then depending on which registrar it is as well, we get some good teaching opportunities there. So a lot of my on-calls I did with a few very good registrars who actually let me do all the talking, let me do all the examinations. They did the note taking, and then they filled in any deficits that I had, and we basically saw the patient together, and then they use that to sort of teach me and do the sort of work-based assessments that we need to do as well. So those were also really good shifts. And then as an SHO as well, we have nights and weekends, which are slightly different.
Okay. And I guess you were saying that obviously you worked in a tertiary centre, a big trauma centre, where you always had a registrar on call with you, and then there was a separate registrar who was assigned to the theatre, whereas you said in smaller centres like district general hospitals, you may be the SHO on call by yourself for orthopedics, and your registrar is in the operating theatre. So how do you think working in a tertiary centre and having that registrar on call with you, is that better? Is that worse, do you think?
I think there are pros and cons to it. I think from a teaching perspective and from a junior support perspective, I felt a lot safer and a lot more comfortable knowing that I have a registrar that's on call with me. I'm only an F2. I say that, I'm only an F2, so for me, I'm still very junior in my training. Had I been thrust into an on-call straight away at the start of my first F2 placements, as the SHO on-call on my own, taking all the orthopedic referrals, I think I would have found that a bit overwhelming. But I think it's nice that I was able to sort of grow into the role with the registrars that I had. So at the start of the placement, it was very much, I didn't take any referrals, and I would sort of note take and sort of watch, as it were, to start with. But as the placement went on, the registrar that I had, like I said, was very, very keen to teach and knew that I was interested in orthopedics. So he took the opportunity to let me take the lead on some of the patients, if we weren't too busy. So there was sort of that switch. I can imagine that if you're in a DGH, it's not necessarily that you would get different types of patients than some of the ones that you would get in the sort of major trauma centers and tertiary centers. But I think, being on call on your own, you'd because you're sort of put into that position, you would have to learn very quickly. And I think that in itself can be a good learning experience too. I think it just depends on the type of person you are. There are pros and cons to sort of both ways, but I can see why it's done that way.
Yeah, no, certainly. The other thing that kind of strikes fear into the heart of medical students, even foundation doctors, is the trauma meeting, because they've got this picture of being sat in the chair in the middle of the trauma meeting and being, fired questions from all angles by consultants about x-rays and asked to present. What are your thoughts on the trauma meeting, and has that been the case for you, or?
So I have two very different experiences of the trauma meeting. So as I said, I did my orthopedic placement, my MSK placement at medical school at a district general hospital, where they have a little bit more time in the trauma meeting. So it's not so much it's not that they're not as busy, because some DGHs are very busy. It's just that they allotted a lot more time for their trauma. So their trauma meeting was an hour long, and what they did there, which was that sort of experience where they sat all the medical students sort of at the front of the room, and then one by one they went through asking them to present the x-rays, which sounds very scary, but actually it was done in a very supportive way. So if you made a mistake, or you didn't know, or you didn't get the fine, you couldn't see it, no one would tell you off or anything like that. It was very much then used as a teaching opportunity to explain the x-ray and to show you. It's very different to what I've had at UHCW. The trauma meetings go at a much quicker pace, so there's not always, generally the consultants at the front of the room at UHCW, and then the juniors and the registrars sort of sit more towards the back, and there's not so much of the firing of questions. It's the consultants discussing the imaging and what they want to do. So you sort of have to pick out the information from there.
Okay.
And then,
all right.
Yeah, and then every so often there'll be one case where they will ask the juniors. Some of the consultants are better at it than others, at getting the juniors involved. But so there is that teaching element there too, just not as often.
Okay, fine. No, that's fair enough. So I guess now you've done your 4-month orthopedic placement, you're obviously interested in orthopedics as well. What would you say some of the best parts of it have been?
Oh, so for me, the best parts were not being on the ward all the time. So I think it's very easy for you to just the main jobs of the SHO are ward based, and to look after the ward patients and to look after their medical problems as well as their sort of orthopedic problems. But I think some of the best times I had during my orthopedic placements were actually when I got to go down to fracture clinic, and I got to see patients and assess them myself, and then present them to the registrar or the consultant, and also the time that I got in theatre as well. I think those for me were the best times, but they're not opportunities that sort of present themselves to you unless you sort of seek them out. So for the core trainees, there's more of a requirement to go and do these things. You have to get a certain number of hours in theatre, and you have to do a certain number of hip fixations as a core trainee. But as an F2, those requirements aren't really don't really apply to you. So I think seeking out those opportunities and going to do all those extra things, because I knew the ward would be okay after I'd dealt with the ward jobs, or we as a team agreed that the A&P and one other member could deal with what's going on in the ward, was definitely sort of the highlights of the placement for me. And then I had some really good registrars and consultants who were very supportive and allowed me to have those opportunities.
Okay.
So yeah, that for me was the best part.
And I guess you've kind of alluded to it a little bit already, but for those people who are starting their placement in orthopedics as an SHO and they're interested in orthopedics, what can they do, or what should they do to try and get ahead or make themselves competitive for further applications?
So yeah, I mean there are lots of things. So I think for all types of applications, the first thing you should always do is look at sort of the next stage ahead for the applications. Look what you need to do to score the points on the applications themselves, really. I think for orthopedics, that's no different. For people about to start their orthopedic placement, I think, if you could speak to some of the consultants beforehand, see if they've got any projects or audits that are going on that you could get involved with. You can do that as an F1 or whilst you're not on your orthopedic placement. So that's a good way to get started. Publications always help, and that's the projects are the way to get those. Examinations, so the MRCS examinations, if you can do those early, that's always a good way to sort of start getting not just extra points, but it shows interest when you're applying for your either course, surgical training, or however you apply for it. And then I suppose just put yourself out there. Let the consultants and the registrars know that you're keen in orthopedics. Get involved. When you're doing your work-based assessment, don't just stick to the things that they would expect in F2 to be able to do. If you get the opportunity to do something like a neurological assessment, or like an Asia chart, or something different, and that can be assessed under supervision, then do that too. Again, it just shows interest.
Okay, so essentially just kind of putting yourself out there and being proactive is the key way, and just kind of seeing what opportunities fall your way and what you can chase as well.
Yeah, I mean, so there are things obviously you can chase. Like, I mean, you can always seek out projects. You just have to find the right people for that. And again, at a tertiary centre like that was fairly easy to do. Whereas at a DGH it might be a little bit more difficult. But that doesn't mean that you can't ask someone else within the trust. It doesn't have to be at that hospital that you're working at. And then audits get done at all hospitals, so you can always get involved with an audit. I think, like I said, I think the majority of it is just putting yourself out there. If you put yourself out there for the opportunities and just sort of taking everything you can, just get involved as much as you can, I think that's sort of the best ways to, especially to show your consultants that you're interested. If they know you're interested and you show that you're interested, generally they help you a lot more and put more opportunities your way.
Fine. And I guess now, kind of flipping that question around about what you enjoyed about your placement, what were the kind of challenges or some of the worst parts about your placement? I can put it like that.
Yeah, so I think starting the placement was definitely a challenge. So I'd come into this placement having done 4 months of general surgery and then 8 months of general medicine. And had this overwhelming feeling of not knowing anything. I mean, obviously I'd been to medical school and I'd done my MSK placement, and I was interested in orthopedics, but it's just some of those on calls and those nights just seem very, very daunting. And I actually remember my first night shift. I think that was the biggest challenge for me. So at UHCW we cross cover plastics as well, and cross covering specialties is not anything new. It happens at most hospitals. And I think actually orthopedics and plastics is probably a good fit for cross cover. But I went into my first night shift, and actually you would know, you were the registrar.
I was waiting to see if you remembered that or not.
Yeah, no, I remember. So my first set of night shifts were actually with RM. We did 4 nights in a row. So I went into that feeling like I didn't really know anything about orthopedics, and then also that I didn't know anything about plastics, and felt like I'd get in the way more than anything. And yeah, it's a bit daunting being, only one SHO who's with the registrar on a night shift, where any countless things could go wrong. And actually our first night was a very busy one. So
It was. We were there till 5, 6 o'clock in the morning. I remember stitching,
Yeah,
people's wounds down in A&E and doing all sorts of things. But
exactly.
it was
Yeah.
my first night as a registrar as well. So it wasn't just you who was feeling a bit lost. I was also thinking, I'm used to being an SHO. I'm not used to being a registrar.
Yeah, I mean, so for me, that was the biggest challenge, and I think any sort of on call and nights can be challenging, especially when it
Yeah.
gets really busy. I wouldn't say they're the worst parts of the job, because I haven't really found that there are any sort of worst parts, as it were. They're just bits that are a bit more challenging and a bit harder. And like I say, that first set of nights, I'll definitely remember those. I don't think I've had a bit one as busy as that first night since, and I've ended up doing sort of 5 or 6 sets of nights. Having
Neither
that.
have I. Honestly, I've not had nights as busy as those. I was expecting my next set of nights to be as busy as those, and I saw half as many patients in those nights. So I guess it's just how it falls, really.
Yeah.
Okay, so it's that kind of anxiety or fear that everyone has, I guess, because you were just starting as a SHO as well, so you've got that step up, and then on top of that,
Yeah.
a new placement as well.
Yeah, so I mean, it's my first SHO role, and it was a new placement. And orthopedics is very different to general medicine, general surgery. It's got its own language. It's got its own set of pathologies and things. And like there is nothing else like it in medicine or surgery. It is very different. So I think it is very sort of specialist, as it were. And that was, again, you get a lot of the anxiety from that too, having to learn a whole specialty. Obviously you have some of that knowledge there already. It's in the deep trenches of your mind. It's there, but you have to sort of dig some of it out and look at things a bit more.
Yeah.
And I think as well, I put extra pressure on myself because I wanted to do orthopedics as a career, and I have that interest. And I'm doing an academic block in orthopedics straight after that clinical rotation. So I think that anxiety was definitely there. But like I was put at ease by, it might have been your first set of nights as a registrar, but you definitely put my mind at ease, and all the registrars I've worked with on calls and nights and weekends have all done that. So I think
Great, thanks. You can come back. You can come back on our channel now. I didn't pay you to say that. I just want to get that on record.
Yeah, so I think that as much as you feel that, other people feel that too. And I think all the seniors in the team that have worked there that stay in the team, and the AMPs know that too. And everyone actually is very supportive. So I think even though you have that, there's no need to feel like that.
Fair enough. I mean, I wanted to put off talking about COVID for as long as possible, but I think we've probably reached that point now. So obviously, this has been a long-standing feature of your F1 year and also most of your F2 year. In orthopedics, how did that change what you did in the placement, or did it?
So I think it made things. So it definitely did change it. From having spoke to people who've done the orthopedic placement that I've been on before me and before COVID, there definitely has been a change to the way the teams work and the workload. There's been no elective procedures during the main waves, so that reduced the workload from the elective point of view. And even when sort of electives had sort of restarted, they get the patients are actually on different wards, so they're not on our general orthopedic wards, which were considered to be amber zones. They're put into sort of a green pathway ward, which have their own SHOs that look after them during the day. So our input to those patients was actually very, very minimal. Before I was on orthopedics, just before they had got rid of the team structure and just were seeing all the orthopedic patients together, and then sort of reintroduced the team structure. I think just so there has been a change in the way the department works a little bit, and then sort of as the sort of peaks sort of ramped up, the sort of inpatient numbers and then the number of admissions had significantly dropped. So I think from a workload perspective, it did decrease for a little while. It just meant that we were able to help out with the medical outliers team when they were seeing their patients, who were then subsequently put onto our wards. So there was, as well as dealing with sort of medical issues from the orthopedic patients, we were having to become medical SHOs for a time as well.
How was it
You know,
working with those consultants who, you've seen as your consultants and your seniors, and suddenly you're doing the same job as them, looking after medical patients on the medical wards?
yeah, it's I mean, it's very, I mean, it's very strange to see sort of consultants and registrars to work as SHOs. You know, it's not something that you see, but I think it's a testament to them as well that you know, they were willing to help out and pitch in, and just, you know, knowing that they're not consultants in medicine, but doing what they could, was good. And you know, and a large number of our colleagues got redeployed as well. So I unfortunately could not be redeployed. Fortunately or unfortunately, depending on how you look at that, due to sort of risk factors and health conditions. So I stayed on orthopedics. However, other members of the team, other SHOs, were redeployed to ITU and to acute medicine. So, you know, we also had to deal with a workforce that was, or a team that was sort of short on numbers, and then with sickness as well, and people having to take their isolation period stuff, that, you know, numbers in the department did become quite small, going to the point where we would maybe have 1-2 SHOs for all 4 teams in one day. But I think we just cope with that, and we managed. And, you know, like I said, the team are very good at managing. And you know, it's the pandemic itself, and the way that everyone worked, has just made everyone just pitch in where they can. And, you know, the consultants and registrars were no different.
I see. Is there anything that sticks out in particular? Any one day, one patient, one incident that sticks out, that kind of makes you think, you know, this is what I'm going to remember from orthopedics and F2?
So I've had a few of those sort of those one patients, as they were. Unfortunately, at the start of my placement, you know, we were still in the middle of sort of that first wave, or coming out at the end of that first wave. And during that time, as a medical profession, as it were, everyone had seen an increase in mental health illnesses, and people had, you know, as well as talking about their mental health more, if they could, a lot of people had that isolation and loneliness, leading them for things like depression and things to get worse. Unfortunately, it was my second day on orthopedics. We had a patient who had a suicide attempt from jumping off the building. I think that patient would stick out with to me from my placement. That patient remained an inpatient for the entirety of my 4-month placement, and I've done extra shifts in the orthopedic department since then, and they are still a patient. There's still a patient there. So knowing their injury,
that kind of mental health aspect as well to the lockdown, and, you know, how it's affected so many people, the isolation, and you know, causing them to, you know, deteriorate and potentially, you know, try and commit suicide. I think, yeah, I've noticed exactly the same thing. There's been a whole kind of swathe of those that we've noticed.
Yeah, like I said, that was just that one patient, and we've had a few more of those, and, you know, maybe not as severely injured as that one, but, you know, I think those are the patients to stick out, and the ones that have, you know, for me, it's always the big trauma calls. So as a part of our on calls, we attend every trauma call, which sounds very exciting, but and sometimes it is, you know, it's very fast paced. A very fast-paced team working to sort of stabilize a patient and then figure out what their injuries are, getting into the scanner. But a lot of those trauma calls with some of the sort of higher energy mechanisms, they're the ones that sort of stick out the most. You know, those are the ones that I think I'll remember for the longest time.
Yeah, and I guess now, thinking back to your orthopedic placement, now that you're kind of out the other side of it as such, are there any sort of final comments that you'd kind of use to sum up your placement?
So I really enjoyed my placement. I thought it was fantastic. You know, I don't know whether it was just the hospital I was working in, the team I was working with, the people I worked with, or whether it is orthopedics. I mean, I really enjoy orthopedics as a specialty, and I really enjoyed working with all the team that I work with. So I'd say that anyone who is reluctant or apprehensive about going into their orthopedic placement, definitely don't need to be. It's a great specialty. those stereotypes that I mentioned earlier don't really exist in orthopedics. You know, everyone's very friendly, everyone's inclusive. You know, you'll have a good time, and you definitely get out, and just with anything, you definitely get out of it what you put in. So if you want to have a good experience, just put yourself out there. I think, you know, that's, if I had to do it again, I would have done that earlier. You know, I was very apprehensive at first, spent the first couple of weeks finding my feet, but you know, not necessarily taking advantage of all the opportunities that was there. And it was only when one of the registrars sort of pushed me a little bit. He said, you are interested in this, you know, you should be doing this and you should do that. You should go to fracture clinic, you should go to theatre. You know, that's when I really started to take that advice seriously and do those things. And whilst, you know, it's very nerve-wracking at first to do it the first time, to go to fracture clinic the first time and to see a patient, and then the first time I dictated a letter, and the first time I went to theatre and assisted.
I think, kind of summing up from kind of what you were saying, is trying to put yourself out there, taking the opportunities and seeking out those senior colleagues, whether they're, you know, senior SHOs, registrars, consultants, etc., who kind of know the game and know what you need to do and how you can kind of show your interest and get more experience. Thank you very much for giving up your time. I really, really appreciate that. And I know you're going to have certainly helped a lot of people who are especially anxious or nervous about starting orthopedics. I will say, if you want to check out this interview or check out any of the other interviews for any of the people watching, then please check out ortho.buzz on Instagram or Orthobuzz on YouTube. And next time we'll be looking at the orthopedic registrar grade and the next stage in orthopedic training as such. So thank you very much for your time, Danny. I really, really appreciate it.